to take some questions. You want to have Pam come up now? Sure.
Panel members have any questions or whatever, or Chris, you'd be happy to take the time to do one at a time.
Sure. Okay.
I'm just wondering, what is your reflection in terms of what, looking back at the report, what you would have done differently?
That's an interesting question, and the question is, looking back at that report, was there something that I think we would have done differently on reflection? And I can't say off the top of my head that I do. I think we had, just as you're having, we had a lot of public input and open testimony from people from a very wide range of perspectives. And you have a wonderful committee of a very diverse group of people. So I can't think of anything, but I'll get back to you if I do. Bernie.
Can you also reflect on what has changed since your report has come out that you think what's changed since your report was issued that we should pay attention to that wasn't on your radar screen back in 1997?
What has changed since the report came out that wasn't on the radar screen then? I think, and you know, this is probably something interesting for your committee to reflect on too, because you have a wide range of expertise here. But I think that for the better, what has changed is more open discussion of this issue and much more availability of what we know to be good care in this area. What is very different is this accountability framework that we're in now. The fact that we are measuring quality of care and making those that information available is good and is reassuring, but is woefully inadequate and could be very misleading when we think about how quality measures and particularly measures of resource use might be folded into some way of evaluating end-of-life care that ends up not really getting us the personalized care that we want. So I do worry that we might rush too much into thinking if we just get the right measures, then everything will be okay. So that's something something very different. And then the other thing is what I mentioned, that I think that in 1997 we were facing a public who didn't want to talk about death and dying. And now we're facing a political process that uses it as part of a political debate that is very distorting to the goals. So it's a different kind of cultural issue in some ways, and I would urge you to, you know, think it through and what the implications are in terms of that challenge. Yeah. Yeah.
As I looked at that report, lots of wonderful recommendations. But we're back here again. So clearly, someone thought that something was not complete.
Right.
And not perfect. Is it just going to make so much change for you to time? You have to cycle back every 15 years? Or were there constraints or blocks or reasons that things did not turn out as much change as we would have liked?
Yeah.
What were the constraints? What were the bottlenecks? What were the problems?
Right.
If you were, what's the core problem?
So Steve Pauker is asking, what are, of the things that didn't happen between then and now, what were the constraints, what were the bottlenecks, what's the core problem that now you get to help us face as a nation? So I think that I've addressed a number of those, Steve, in terms of the scorecard here. I didn't give us grades in these various areas. But I think I would say still that the way our healthcare system is set up, the way we reward people, and sort of the culture of how we look at modern medicine doesn't really support. The advances that have been made in spite of that, not because of it. And so as we think about where the money comes from, if you look at the big academic centers and the huge, you know, glossy buildings that are going up everywhere at this time where we think we don't have enough money for health care, and you're wondering, you know, who's paying for that, where is that coming from? It's coming from technology. It's coming from technology that is highly touted to be life-saving, and in many cases is, but that's where the focus is. And that's where people like to sell. Nobody puts up a billboard outside their academic medical center saying, we're the best place to die. You know, that it's very hard to sort of celebrate that. And yet, the people who work in this field can tell you that when a family member leaves a hospital after a patient has died in a hospital and it's been a bad experience, that stays with that person for the rest of their life, that memory does, and their attitude about the hospital and the whole thing. And it's in our power to change those memories and make that different. But we don't pay for memories, you know, in healthcare, or for positive experiences in that regard, with a few exceptions. And that's why I use the birth analogy. I really think we can begin to think about not necessarily having it be the lead marketing tool for hospitals. I don't think that's ever going to happen, nor would you want it to happen. But you would want people to be able to expect that in any decent American hospital, if they happen to be facing a really serious illness there, that they will get this kind of access to really good palliative care. So it's about payment and about the culture of the institutions. And so what better time now when we're talking about really taking a look at our whole, how we think about healthcare, how we pay for healthcare, as David knows, in this country, to think about what would be the levers that could begin to change that value equation. Diane.
So Chris, I agree with you that the accountability shift in the culture of the delivery of health care is real, although I don't think it's really hit its stride yet for a whole number of reasons. But a big piece, what's really driving this, or at least my fear, is that what's really driving it is not an overarching concern about quality, but an overarching concern about cost. And that in order to stop doing things just to save money, we've put the quality safety net in place to try to protect patients from an excess zeal to cut spending that might actually hurt people. So we've tried to create a filter or safety net to protect patients against excess cost cutting. So as Don Berwick is wont to say, accountability improves value because by improving quality, you reduce costs. And I think palliative care is the poster child for that kind of model of care. My big worry is that the public perception will be, if we are not very careful, that palliative care and care focused on high quality during serious illness is actually just a fig leaf for taking care away from people. And certainly the death panel debate has crystallized that in people's minds. So how would you advise us as a committee to negotiate that risk, which I think is quite real?
Well, let me say two things about that. One is that I think you should talk about it very candidly and vigorously in your committee, because I do think that's a different environment now than we faced 15 years ago. But I also am a little bit optimistic about that environment. I don't think it's quite, well, because having been part of the IOM committees that did that report on crossing the quality chasm and to err as human, you know, that there wasn't a lot of discussion about costs during that time. It was just this absolute alarm at the information we had about mistakes and errors and needless pain and suffering, as well as deaths of patients. And then this notion of waste that began to become part of it. And the other reason I'm optimistic, I might as well put in a plug while I'm here, is that tomorrow the Choosing Wisely campaign is going to release another 90 overused medical tests and treatments that are designated as overused by the medical specialists themselves, who are experts in those fields. Some of you may know, 8-9 months ago, we released the first list of 45 lists of things from 9 specialties. It's gotten a huge amount of attention. And now we have these 16 new specialties that are going to release lists tomorrow, and then another group of almost 15 specialties that will follow about 6 months after that. So we now have actually almost every major medical specialty society stepping forward and saying, we actually waste, we actually do things we shouldn't be doing. In this current release that's happening tomorrow, the American Geriatric Society is represented and the American Academy of Hospice and Palliative Medicine. So there will be things about feeding tubes and advanced dementia, for example, and recommendations. This is embargoed until tomorrow, but I think I can tell you. So I think the interest in and the extraordinary public media coverage of this campaign, I mean, I've just been on the phone all day talking to press about this, really gives me hope that we're beyond that rationing thing, because, I mean, I think we need to keep the people who know how to manipulate public opinion from misusing it, but I do think that, frankly, so many patients and families have huge, high-deductible insurance plans now and understand that how much they pay out of pocket and how much comes from their employer as well. So people are informed about that now. It's not like health insurance is a free ticket anymore. So I think people are beginning to ask this question about value, and in a more sophisticated way. So I guess I'm kind of hopeful that you're in exactly the right time to address that issue.
Well, you're speaking some to the question I was going to ask around the power of the spread of information technology and the ability to aggregate data and to publish it and to compare and to gain insight on our own about patterns that we have, coupled with taking us potentially, I mean, it could be the downside or the upside, out of the financial structure jail that we've been caught in. That it does seem, as you look at the dual demonstration preparation that we see in California, you look at relabeling, because ACA took HMOs and called them ACOs, and suddenly they were acceptable. So it seems like language can matter, that the shared savings and the move to population health management, but specifically moving the risk for long-term care, because I'm wondering if some of this doesn't get caught also in a long-term care paradigm. And we see under the duals where that shift literally goes to the plans and the physicians, a sudden interest in organizing community care networks. And I'm just wondering what your thoughts are about those forces for change.
Yeah, you're exactly right, and that's one of the reasons why I think I'm optimistic. But a lot of people who are taking on that risk don't have this experience to really manage it. And so, you know, it would have been good if there could have been some language in there about palliative care and the need for that as part of these entities. But, you know, smart people are hopefully going to figure that out for themselves. I guess that gets to the first question about, is there anything I think we should have done more of? And as a geriatrician, I'm embarrassed to say this, but I think attention to long-term care is probably a big one, and I hope that you'll do that. If you look at where the emphasis of the population is right now and where it's going, those are going to be the real pressures, and I think we have more understanding now and more opportunity with these dual demonstrations and other accountability mechanisms where, you know, the providers have to really think about what happens to the patient after they leave the hospital and before they come back to the hospital, and which, you know, used to just be a black box as far as the acute care system was concerned. Yeah, David. Yeah.
And so let me mention two things at the end if you could respond to.
Okay, sure.
First, language matters.
Right.
A lot has changed since 1997. In 1997, your committee made a conscious decision to use the word death.
Right.
All right?
Right.
Maybe talk a little bit about that. And then
Okay.
secondly, some people debate when life begins. We have a pretty good idea when life ends.
Right, right. At least
But
we
there's
don't.
a great debate
Yeah.
about what's the beginning of the end of life. So what, if any, comments do you have about that?
Thank you. That's a very good question. So you're absolutely right, and I did mention that we had a very conscious decision to use this word death in the title, because at the time, you know, even medical people weren't even talking about people dying. Nobody in a hospital ever died. They expired, you know. I mean, it was just, there was just this really amazing inability to even talk about what it was that was going on. And James Tulsky, who's sitting here, has actually done a lot of that research about physicians and trainees talking to patients about DNR decisions and ways that the patient had no clue what they were talking about, you know. So at least that was our goal here, was to sort of say, hey, this is what we're talking about. So I think we achieved that end. But as I said earlier, I think you face a different cultural environment, and I think you should have that discussion about the language. I'm quite impressed, for example, with this Choosing Wisely campaign, that we were really successful. We got professional advice about the language. We did focus groups, we tested all these words, et cetera. And it really does, well, I don't have to tell Bill this, but it really does matter the language that you use and what impact you have on people. So I think it's worth spending a good deal of time on that. As to the question of when end of life begins, that's the point I think I was trying to make about redefining the population that needs this kind of care. That because if you look at all of the data for years and years about how much money Medicare spends in the last year of life, and we all have spouted that number is usually 25 or 30%, and has been actually since the very beginning of the Medicare program. Uwe Reinhardt always says that death is nature's way of telling you you've been very sick. And that's, you know, what that, so the goal there is, let's take care of the patients who are very sick and not force ourselves to define them as dying before they get the care that they need. And that's where I think the real brilliance of the sort of newly defined palliative care specialty can really be helpful here, because you can define a trajectory of care that reduces highly risky, highly intrusive, less likely to be successful invasive procedures, and in a way that doesn't make it all or nothing for that patient, but really serves the patient and what they need at that moment, and is willing to change and willing to be flexible. Because I think that's one of the things that really scares patients the most, when they feel they have to cut off all access to something and close a door behind them, when in fact, you know, all you're saying is that you need different kind of medical care right now. What is it that your goals are? What is it that you're experiencing at this time? So, so I would urge you not to try to answer that question, I guess would be my answer.
I know your time is limited. And if there's nothing else from any of the panel members, then thank you very much, Chris, for being with us.
Thank you, and thank you for your work. Yeah.
And now if we can have our own Dr. Pam Hines come up and you know, talk to us about the 2003 Alwyn report, When Children Die. A very uplifting report here. But